So good evening, everybody, and welcome to the fourth of our kidney health series for GPs. My name's Anne-Marie Swoboda, and I'm the Medical Director of the GP Liaison Unit, and I'm a GP working in private practice. So before we begin today's session, we wish to acknowledge the traditional custodians of the land that we're meeting on, the Ngunnawal people, and we wish to acknowledge and respect their continuing culture and contribution they made to the life of this city and the region. And we pay our respects to their elders past, present and emerging. And we'd also like to acknowledge any Aboriginal and Torres Strait Islander people who may be joining us for today's session. So you'll all be unmuted today, but please do feel free to make this as interactive as possible and put your questions into the QA box or the chat function, and I'll continue to monitor those and ask our presenter as we go along. And at the end, there'll also be an opportunity for any questions as well. And also, we'd like you to complete the evaluation questionnaire at the end of this session. That really helps us with planning for future sessions. So this is a really important topic for GPs. Kidney disease is very prevalent in our adult population, and we've been focusing on kidney health from the renal side over the last 3 webinars, but this time we're going to be looking at the plumbing side. So it's my pleasure this evening to introduce Acting Professor Hodo Haxhimolla. And Hodo is an experienced urological surgeon. He completed his degree at the University of New South Wales in 1992 and did his urological fellowship training in 2002. And he's performed more than 1,500 cases of minimally invasive radical prostatectomies and kidney surgeries. So welcome, Hodo. Thank you for joining us today. I'm going to hand it over to you to start off.
Thank you very much, Anne-Marie, and it's a pleasure to join you guys tonight, this evening, for this talk on renal issues pertaining to the urological problems that you face in the community. As you mentioned, I mean, we do deal with plumbing, and as such, plumbing usually is post-obstructive cause of renal impairment. So if you look at the classification of the renal impairment, which you would have touched on with renal physicians before. They would have talked about pre-renal, renal, and post-renal causes of renal impairment. So the pre-renal, obviously, it's something that would be more to do with acute medicine, with ABC that you would be attending to patients that are dehydrated for whatever reason, and you need to give them fluids. Renal causes, obviously, they're very complex, and we've covered them in 3 sessions, so I think that's a fair call.
Tom did a great job.
That's right.
Yeah.
Whereas with us, with the plumbing, we are very simple. We have to do making sure that there's no blockages of the passage. So that's what we look at. And I will touch a few things, like, for example, patients that have had tumours of the kidney, which obviously the kidney has been extracted, or if there was a partial extraction. But mainly is to do is post-obstructive and post-renal causes. So as you can see here, the main one would be in keeping...
Let me fix it. I don't know why that won't work. Let's try now.
Our next slide would be...
There we go.
Yeah, so if you look at causes of retention, which you could look at post-outlet obstruction, retention, benign prostatic hyperplasia, prostate cancer. That's the obvious ones that we see. Bladder neck stenosis, strictures, and that can be sometimes instrumentation, can be infections, can be tumors that can be causing that. Urethral strictures, again, can be simple things like previous catheterizations for patients, previous instrumentation. Small percentage of patients, for example, they might have had a previous TRP. They can sometimes present with strictures, and it's usually less than 5% of those patients. Foreign body introduction, I mean, that can be, we talked about either iatrogenic or even sort of patient-induced sometimes. You see that sometimes in the emergency department, people coming in with foreign bodies. Neurogenic causes, which are sphincter induced, which is patients that might have had strokes, they might have spina bifida, for example. You can see that sometimes as they get older, they might have, and you always need to make sure that if they've been self-catheterizing, that these patients that you look at their renal function also, that it doesn't deteriorate, because they can develop scarring of the kidneys also. You can have sometimes prolapse, and that's more common probably in women. With prolapse, you can have obstruction. And the drusen function, obviously the drusen failure, which can be part of long-standing obstruction, which some of these causes can lead to. So it's a very variable etiology, as you can see, and all of those things that need to be addressed. So most of the patients that obviously that come in practice are going to be benign prostatic hyperplasia. A lot of them would have had symptoms for a period of time, and sometimes it can be insidious. Sometimes you find that patients say, look, I don't have a lot of symptoms, and yet they might have very high plasmoid residual. So a common thing that you would do in your practice would be looking at ultrasounds as your baseline, and then repeating those ultrasounds over a period of time to see how they're responding either to your treatment or if they've had treatment, how is that treatment sort of improved their condition. So ultrasound is very, very useful in terms of monitoring it and managing it. With prostate cancer, it's not very common that prostate cancer can lead to severe obstruction, but these cases are usually either if they're coming from the transitional zone or if it's very advanced. So if your cancer prostate is advanced, then obviously that can lead to obstruction. In that case, obviously the standard PSA testing that would reveal that it is cancer prostate that's causing the issue. One thing that we have to be careful when we do the PSA in these cases is that if they had an obstruction, if they had catheterization, we have to make sure that these patients we account for that when we do the PSA testing, so we don't, and then we can repeat it. Sometimes we do the PSA testing even if they have urinary retention, or to make sure that there's no prostatitis, because that can also be a benchmark in how you follow these patients afterwards. And how their prostatitis also is being treated and managed. So by dropping the PSA, obviously that's your clue. There's been a significant inflammation going on, and that would be helpful in managing it.
Can I ask a question about residual volume? What's a normal post-void residual?
That's a good question. So normally what I say to patients is that when I look at the pre and post-void residual, it does give us a lot of information. If, for example, you have 500 mils in the bladder, if you have less than 50 mils there behind, that would be acceptable. Okay. That's for males, of course. So in females, you want to have as little as possible. Even 50 mils is high.
Really?
Because that's what's going to lead to recurrent urinary tract infections.
Yeah.
So you can't utilize the most common cause of that is going to be not emptying the bladder full. Yeah. So less than 10% is acceptable. But watch that space, because over time, obviously, that could increase, and they will need. And in view of their symptoms, if they have more than 10%, then obviously that needs to be addressed and treated so it doesn't become a chronic problem. So there will be some of the features there with bladder neck stenosis and urethral strictures. Obviously, it would require a different sort of treatment pathway. With any stricture, normally what we try and attempt to do is relieve the stricture, dilate it. So sometimes we do it with dilatation with the S-curve dilators. These days, I prefer not to do optical urethrotomies. You might have seen that.
To do what?
Optical urethrotomy.
I don't know what that is.
Sometimes you might have seen that in your during your terms. But optical urethrotomy is you go in, you identify the stricture, and then you cut the stricture using an optical urethrodome. It's an effective way of initially treating that, but the problem long term with that is that it can lengthen the stricture.
Yeah.
and it can become a
Scarring.
bigger problem.
Yeah.
So more scarring. So they say that you can do one optical urethrotomy. I prefer to do 0. So what I do is I do a dilatation, I put a guide wire, I dilate the stricture, and then once we dilate the stricture, we can then sort of do self-catheterization. So ideally, if the patients can learn how to self-catheterize, and I ask them usually to do it for about 3 months to 6 months, once a day, passing the catheter, they can be taught how to do that with a clinical nurse, and that usually will stabilize it. In a younger person, they might need to have a formal repair of the stricture with buccal mucosal graft. So buccal mucosal graft has been very effective. It's been with long-standing good outcomes with that. They usually take a bit of area of buccal mucosa from the inner part of the mouth, and then they do the repair of the urethra, and they put it like an outlay over the area where the scar is. So they open that, and then they put stitches. I don't do that here. And normally I would send the patients to Sydney to have that done. It's a fairly subspeciality area. Not many of us do that. And,
how does the GP know if there's a urethral stricture from?
Well,
like, how do you
you
differentiate between these?
It's very hard to
No.
differentiate.
Okay.
And one way, I mean, you can sometimes work it out is that if, for example, if the patient has got a small prostate,
Yeah.
so you have a small prostate and you have a high residual, so well, something's
not right.
Something's not right. And also in a younger patient. So a younger patient, they might have that, or if they had previous surgery. So if they had previous surgery, previous TURP, then you'll find that that's the case.
So if they have a high residual on ultrasound, really they then need to go on to have a cystoscopy. They need a urology review.
Cystoscopy is a diagnostic test. Now, in the absence of a previous surgery to the prostate, for example, and the patient is in more than 40 years of age, they've had some enlargement to the prostate on the ultrasound, you can try your alpha blockers. So you can try as an alpha blocker. If you find that the patient comes back and says to you, fantastic, doc, you've cured my problem.
Then we don't need it.
Then you don't need a cystoscopy for that. It's very likely to do with the prostate.
Yeah.
But if they're not responding to alpha blockers, they're still having a high residual, they're a younger patient, then that's a concern.
Yeah.
The other trick that you can find sometimes with these patients is that if they come to the young patient and they say, look, when I pass urine, I've got spraying on voiding. So spraying on voiding happens because you lose the laminar flow. So the laminar flow allows you to have a good stream without having double stream. Whereas once you have stricture, you lose that. You have turbulence in your flow, and that leads to spraying. And sometimes the stricture can be at the tip of the penis. So you have a meatal stenosis, or you can see that when you examine the patient. It's not very common, but it can be sometimes submeatal stenosis, and that is not as evident when you examine it.
So can I ask you, so I recently had a patient who had a urethral stricture, an elderly woman who actually, it was very hard to diagnose what the problem was, and she's had an SBC and a whole range of things, had cystoscopies, multiple cystoscopies, but actually she's had a gynecological cancer. But pelvic ultrasound was completely normal. There was no...
It's not uncommon. It's a common condition that you would see in lichen sclerosis.
Yes, so she didn't have lichen sclerosis.
So lichen sclerosis and gynecological malignancies that can do that. And sometimes radiation. So in females that have had radiotherapy, for example, for endometrial cancer, you'll find that that area is affected. And you'll find that they'll probably have a stricture. Now that is a difficult one to treat.
Yes.
Because normally, if there was no radiation treatment in the area and there's no surgical for malignancy, in females sometimes it can be related to lack of estrogen. So lack of estrogen can sometimes lead to dryness of the area. And what I've been doing now for a number of years is I've been recommending for the GPs to consider estrogen therapy, so local estrogen therapy.
Mm.
And I often explain to the patients is the way that you look at that is like, when people, for example, have, dryness of the hands or the skin, so you use a moisturizer. So the moisturizer for that area is going to be estrogen creams.
Yeah.
And the thing that I, however, as a urologist, I don't like to prescribe it.
No, you shouldn't be.
Because of the concern that I would have, for example, if they have any other issues like breast cancer, family history and stuff, and that I think that is probably more appropriate for you guys in general practice.
Absolutely,
to review that and then discuss that.
Yeah.
I've had even a few cases, for example, where patients did have breast cancer, they have had chemo for that, and obviously there were findings that were quite significant distal urethral atrophy.
Yes.
Which we then liaised with the oncologist, and they were happy for them to, for example, in that particular case, have some topical estrogen, and that it certainly helps. And it also helps with recurrent UTIs.
Yeah.
So that's a good treatment.
Yeah. Okay.
So,
do you want the next one?
I think we'll go to the next slide. So if you look at the
sorry, I somehow.
If you look at the patients that have got, for example, an obstruction secondary to the causes that we mentioned, so sometimes there can be a high pressure obstruction. What that means is that these patients have been in retention for a while, and once you put the indwelling catheter in place, sometimes patients will develop post-obstructive diuresis. So what is post-obstructive diuresis? Well, the way that we define post-obstructive diuresis is that the patients are producing 200 mils of urine per hour in 3 consecutive hours. So that means that they are producing dilute urine.
Yeah.
So urine is not being concentrated. That means that the obstruction has been going on for a while, which has caused changes into the kidney, and then these patients need to be monitored. We need to replace the fluid, not entirely, just the maintenance fluid. So we need to make sure that the electrolyte balance is monitored. So it's very important to check the sodium, potassium for these patients daily, so that they don't lose the sodium and potassium, so because obviously that can lead to cardiac arrhythmias and things that we don't want to see in that kind of a setting. But you'll find that as the renal function improves, and you can have sometimes a dramatic improvement in renal function. Sometimes we've seen creatinine going up to 400, and after the treatment with the simple catheter, you can see that there's quite significant improvement in their renal function. And you'll find that as the improvement of the renal function happens, your post-obstructive diuresis also starts settling. And it improves.
And how long does that post-obstructive diuresis last for?
Usually it settles down within 2 or 3 days.
Yeah.
So by and large, but sometimes it can take longer. Normally, again, we would closely work with our renal physician friends and get them involved because they will need to guide us from the kidney point of view.
Okay, that's important to know about though, because sometimes a patient comes to ED and will have a catheter put in and then be discharged. So it's actually a useful thing for GPs to know.
Absolutely.
So you would recommend monitoring for 3 days, just maybe some UECs and a bit of...
Absolutely.
Yeah.
So I think that's crucial, especially if the patient, hopefully they're not sent home. I mean, if it's an acute setting, what we're talking about, we need to differentiate between someone that's come in with an acute setting of urinary retention. Now, they are highly unlikely to develop post-obstructive diuresis. So we're talking more here on patients that have had chronic obstruction, which has had an impact on the kidney and the kidney function.
Yeah.
So a patient that comes in the emergency department and their renal function is completely normal, the risk of them having post-obstructive diuresis after catheter insertion in an acute setting is very low. And talking about renal issues, I'll get some water. Yeah, so that would be probably the key thing that we would look at the management.
I don't know why that's not working. There we go.
So long-term management, and it really depends on etiology.
Yeah.
So we're looking at Etiology in this case is if it's benign prostatic hyperplasia, then we'll obviously need to treat benign prostatic hyperplasia and address that. If it's a urethral stricture, as we said, we can do dilatation. We can do urethroplasty. If it's prostate cancer, obviously, then we need to treat the cancer on its own merits. Is it you need to do the diagnosis, do the biopsy, staging, and then depending on the patient's age, their health status, we either recommend that the patient has surgery or radiation if that's required, or sometimes even hormonal treatment. If it's an advanced disease with metastatic spread, obviously in that situation you will need to look at hormonal treatment. So that would be in terms of from cancer point of view. I think it will be a different approach. And urogenic bladder. Well, urogenic bladder it's usually a long-term issue, and these patients then you need to look at exactly what happens, and more appropriate test in these patients would be to do urodynamic study.
Right.
And you would have seen probably in your practice quite a lot of urodynamic study reports.
We don't often see them.
You don't see them?
No.
So I like to use a lot of urodynamics in patients with urogenic bladders. Or for example, sometimes even patients that have got a smaller size prostate, but they have a lot of symptoms. So you want to try and differentiate what is the cause of those symptoms.
And how does the urodynamic study determine that it's neurogenic as opposed to some other obstructive cause?
Very good question. I mean, it's a combination of obviously history and the findings of the urodynamics. So what you're trying to determine with urodynamics is to look at what are the pressures generated by the bladder. You know, is there obstruction by the prostate? Okay, or is the bladder, for example, atonic bladder? You know, if the bladder is atonic, well, surgery is not going to help. You know, so it's not going to really help. And in that kind of a setting, for example, those patients might benefit more. Either if, for example, the prostate is not very large, it's a small prostate, either you can do self-catheterization, okay, but if the prostate, for example, is larger, but the bladder is not working at all, you will put a suprapubic catheter in place. So suprapubic catheter in place in this kind of a setting is an effective way of managing it, and you can do it long term. It can be managed in the community easily. The thing that we do find is that sometimes, let's say that the patient has got very distended bladder because it's 1.5 liters chronically distended. Now, some of those patients might recover. I mean, it's not a high percentage of them that they will recover, but some of them will recover. And so you will do an initial urodynamic study, you'll do another one in 6 months, see the difference, is there any improvement? And if there is obviously improvement, then we can look at the options of treating them so we can get them catheter free. Often what I would do in this kind of a setting is patients that have got obstruction with atonic bladder, which has improved, but it becomes still hypocontractile from the urodynamics. What I do is I do a median lobe resection. So we're reducing the median lobe if the median lobe is enlarged. But then what I do is I use the urolift, so pin the lateral lobes. And the reason why I do that is because sometimes these patients, the bladder will still, for some reason, decide that it's not strong enough to work. So if you go in and do a full-on TURP, they will close up. They'll get a stricture. So you won't be able to put catheters back in again.
So then they'll have to have the suprapubic.
And then the problem is that if, let's say that suprapubic falls out, you have no access to urethra. So it means that if you don't break the complete bladder neck area, and you have like a horseshoe area in the bladder neck is still intact, only the posterior part of it, so you will not get a full stricture. Of the bladder neck. So that is very important to try and sort of manage them long term.
Okay. And the neurogenic bladder, the Botox?
So if you have urogenic bladder, and what we're talking about here, urogenic bladder, for example, this is you get bladder hyperreflexia. So on the urodynamics, you get bladder hyperreflexia. So it means that you have sharp contractions, very high pressures that are generated, and have peaks. Now, in those patients, that's Botox injection. So what you do is initially you can try medication, but usually with urogenic bladder is not going to work. So Botox injection is much more effective, and you do the Botox injection, and sometimes you have to repeat it after the initial treatment. But by and large, it's a
so it doesn't have to be ongoing. It's a
no. I mean, with urogenic bladder, you can try it for a few times, but you might need it more frequently initially, every 6 months, and then after a period of time, because the bladder is dilating, so you can get dilatation with Botox, you might not need it as frequently. You might need to do it once a year or less frequently. So depending on how the symptoms develop after that.
Do you know if that's an option that's offered through the public system, Botox?
Yes,
it is, isn't it?
Yeah, it is offered in the public system.
Yeah. Do you want the next slide?
Yes, please. So BPH treatment options, and here, I mean, we've touched pretty much on some of these options, and it basically shows you after these patients have been treated, what has been the improvement, for example, with the QMAX. So QMAX is a flow study, so you've done a simple flow study, and it shows you there the improvement. I must say that, as I mentioned there, so the Urolift is one option. But a combination, I find, is usually works better from the patient's point of view in terms of symptom relief, and usually the QMAX is better. The other thing that I have done is simple prostatectomy, which is you've probably heard the term Millen's prostate enucleation. Or simple prostatectomy. What that means is that we're leaving the prostate. This is for large prostates. So larger prostates, which are more than 100 cc's, you can tackle them with laser. Okay, and you probably need also a morcellator in that kind of a setting.
Yeah.
With very large prostates, I think the best outcomes that I've seen really is for simple Millen's prostatectomy. These are the happiest patients. They have very good outcomes, good flow, minimal incontinence. Minimal incontinence. I mean,
and erectile function preserved.
Erectile function is preserved.
Yeah.
I mean, as you know, the nerves for the erections are going to be on the outside of the prostate. So what we're doing here is, I often explain to patients, it's like having a navel orange, time of orange, mandarins.
Yeah.
So you take a navel orange and you go through the navel area and you just scoop out everything. Yeah. And you still leave the shell behind.
Yeah.
So by doing so, your continence is good because you haven't touched the external sphincter.
Yeah.
Okay. And also your erectile function should be intact. I mean, I always quote about 5%, less than 5% erectile dysfunction for both of them, even a term.
Yeah.
Often you'll find that people say, "Oh, since that procedure, I have not been able to have an erection again." And you have to cover those. Reasons, there can be other reasons, but I think it's important to document that and mention that this is a possible thing that can happen. But because the technique that you use, it's nowhere near where the nerves are, so it shouldn't really have any major impact.
You haven't mentioned in this slide about medication management for BPH.
So the thing is, the reason why I haven't really sort of mentioned that is because these people are beyond the medication.
Okay, yes, so, if you've had obstruction.
So they would have had obstruction for a long time, causing the obstructive symptoms. So, of course, medication will be the primary thing.
Yeah.
And if we're talking about sort of BPH management, you're going to look at watchful waiting, which is no medication, just looking at the fluids and fluid intake. Then you look at medication, as alpha blockers are primary, first line treatment, and a combination then with the Avodart component. So that will be the scale of things that you would look at.
Yeah.
Other important thing to look is also other minimally invasive techniques. You're looking at, for example, Resume. You can look at interstitial laser treatment, which is the echo laser, interstitial laser. I'm a bigger fan of the echo laser than Resume. The problem that I've found with Resume, I was an early adopter of Resume. It's an interesting concept. I don't know whether you've come across that before.
No.
What you do with Resume is you're putting a needle into the prostate, and then you're delivering the water vapor into the prostate. So that causes then damage to the tissue, and you're relying then on your body with immune response to mop up those dead cells. The only thing that I used to find is that because you're penetrating the urethra, they would get these unusual infections. And also they would have a lot of irritant voiding symptoms. So
sounds very unpleasant.
So I mean, it's an easy procedure. It's a day procedure. But the irritant voiding symptoms, because you pretty much, and you can actually see it when you do the procedure. So you put a needle in, and you develop almost like a blister in the urethra. So blister urethra, prosthetic urethra lifts off with a blister. So they do get a lot of it, but the outcomes are reasonably good after 3 months. They do seem to have a good response. With the interstitial laser, which is the echo laser, is what we do, and this is a good treatment. Even patients that are on blood thinners, you don't need to stop the blood thinners. You put 2 needles. It's like doing a biopsy of the prostate. We do a perineal approach. So you put 2 needles in the prostate, and you basically then cook the prostate using the laser. So because you're away from the urethra, so the criteria for that is you need to be away about 1 centimeter away from the urethra and about 1 centimeter away from the bladder neck. That reduces your risk of quite a lot of the urgency, and also the infection rate are much less because you haven't penetrated the urethra. The echo laser also, I'm digressing a bit here, but we are on the topic of the echo laser, we use also for focal therapy. So if you look at cancer of the prostate, if there's a specific small lesion, which we're only finding on MRI, and the PET scan confirms that there's no other lesions in the prostate, we can use focal therapy. And the echo laser is the laser that we use for interstitial therapy for that.
I've not heard of that at all. No. Is that a new thing coming?
It's a new treatment. Which, I've been doing that for the last 12 months. And we've had great
and is that instead of a watchful?
Correct.
Because some people get very anxious about just the watch and wait.
So I still do that. I don't do it for Gleason 6. I do it for a small volume Gleason 7 cancer specific area. So, and I use it exactly like in that setting. Is use it as and I tell the patient it's like watchful waiting. You're treating focal therapy with the lesion itself. Then monitor the PSA, do MRIs, repeat the biopsy, confirming that the lesion is all gone and it's resolved. And usually, what you find in the repeat biopsy is that they will have a bit of scarring and inflammation in that area. Again, because it worked by increasing the temperature in the area, causing apoptosis of those cells, cell death, so it's a very effective treatment.
Good. Is that on that slide?
I think so. We'll go to the next slide.
New topic.
New topic. Obviously, here we're dealing now with the calculi. I mean, this is something that you'll see all the time. So if you look at, in terms of this slide, basically showing you that what happens to the kidney function in patients that have got blockage. Here we're saying bilateral uretary calculi, but
that'd be pretty rare.
It's not very common. It's more in people that have for example, if you have a single kidney, they will have it. But even stone on one kidney will have the same effect. So you will find that, for example, patients that have got renal calculi, that one kidney is fully obstructed, the renal function can deteriorate also. Not as much, of course, because the other kidney is still compensating for that. But if you have a stone and the stone is blocking the ureter and it's complete obstruction, if it's more than 6 weeks, you can get permanent damage to the kidney. And you can see here, more than 4 weeks at the bottom of the slide, you can have permanent damage to the kidney. So that's why I think it's important that when we do treat patients with watchful waiting for stones for them to pass, we often put them on tensiosin to try and smoothen and get this small muscle in the ureter to relax so that they can hopefully expel the stone on their own. You still can get issues with renal impairment and long-standing blockage, and you need to make sure that the stone actually has been proven to have passed. Either they come in with a stone and say, "Doc, can you please send this for analysis," which is great. But if they haven't done that, you need to do another scan.
Yeah.
So I think confirmatory scan is very important
to make sure,
that they actually have passed the stone.
So what's the size of the stone? You haven't got that on this slide.
If you look at the size of the stone,
yeah.
If the stone is less than 4 millimeters,
yeah.
80% of those stones can pass by themselves.
Yeah.
If the stone is, let's say, 5 to 8 millimeters, I would say less than 50% will pass. More than 8 millimeters, it's highly unlikely. I mean, you'll hear occasionally someone comes in and says, "Great, look at this
really small stuff."
Not a common thing. Not a common thing. So they need intervention.
Yeah.
And I think and we can talk about sort of in terms of how do you do it, but if it's a distal stone, you can do primary ureteroscopy. So you can go in there with a telescope and treat it. Now, even with a distal stone, if the stone has been impacted there for a while, you might not be able to get a stent in. Not very common, but it can happen
because of edema and swelling.
Because of edema, swelling, and it's been impacted.
Yeah.
So you can't even put a guide wire through.
Wow.
So sometimes you need to do a nephrostomy and do an antegrade stent to be able to unblock the kidney. And I mean, in these cases, it's important to make sure that even once you've treated the stone, if they've been impacted, that you do actually leave the stent in for a bit longer. And,
because what happens?
The issue is that if, as you know, and this is a common theme in any surgery, so the things that cause scarring is inflammation,
yes,
edema,
yeah,
and ischemia.
Yeah.
So these are the three enemies really that lead to scarring in any part of surgery, and this is not an exception. So that's why I think it's important that these patients, you leave a stent in for a bit longer, and allow for things to settle down, and allow for passive. So the stent, the way that it works is that you leave the stent in place. Every time you pass urine, there's a bit of reflux of urine going backwards, so that passively dilates the ureter.
Right.
So that's how. Okay. So it keeps it patent.
Yeah.
So that's an effective.
I thought reflux was bad.
Well, reflux, as you know, is bad in children.
Yeah.
So if you're less than 2 years of age, that's bad.
Yeah.
In adults, reflux does not lead to scarring.
Okay.
Unless, for example, we're talking, like we talked about previously, of high pressure reflux.
High pressure. Yeah.
So this is not a high pressure.
Yeah.
So we can go to the next slide. So again, sort of here you can see the different stones that we're dealing with. Most of the stones are going to have calcium oxalate stones. Very few of them are going to be obviously uric acid stones, and that's where you can have you can tailor the treatment in the future in terms of management and minimizing risk of stone recurrence. Yeah.
Is that what we mean with allopurinol?
So allopurinol would be for the uric acid. I mean, allopurinol sometimes can also help with even calcium oxalate stones, and because sometimes a bit of uric acid acts as a nidus for the crystallization for calcium oxalate to then deposit. So sometimes that still can be helpful to try and minimize that. Yeah. So stone prevention measures, dietary changes.
What sort of dietary changes?
It's easier said than done, dietary, because as you know, green leafy vegetables are your friend.
Yes.
And a lot of the oxalate is in green leafy vegetables.
Yes.
So so that's not but I mean, you can say, well, if somebody is on calcium supplementation, you need to obviously check that with you guys, with the GP that's looking after them, why they're on that. Are they taking it just because is off the shelf and they're saying, well, this is a good thing to do, or is it because of osteoporosis?
Yeah.
So, I mean, that's a different game, so they obviously need it.
Does calcium supplements increase your chance of stones?
Well, the story is not just on the calcium, it's a combination. So if you're calcium, you have then calcium, vitamin D, so you have then a number of things. Vitamin D, as you know, is the cure for everything.
Yes, depression as well.
So I would have thought that natural vitamin D would have had a major impact on depression.
Yeah, but you get cancer then, skin cancer.
Yes. Damn if you do, damn if you don't.
Yeah.
But so if you look at it, I mean, it then becomes more intricate in terms of how do you manage it and what do you do. But some of these things are, I think, if increasing your fluid intake, I tell all my patients that 50% of your stones will be reduced by taking more water.
Water, yes.
Yeah.
How much water? Patients often ask, how much water?
I mean, the thing is, I often say is that you need to look at the color of urine you produce.
Yes.
So it's not so much what you're drinking, because a lot of the time is you can be, you're drinking soup, for example, you're drinking other things, not necessarily just water.
Yeah.
But it's the amount of urine that you're producing.
Yes.
Some obviously need more for insensible losses.
Yeah.
So the color of the urine does help. You have to be mindful of people that have been on vitamins and things. So obviously that's a bit different. But I would say if you're producing more than 2 liters of urine a day, I think that's good. You probably need to increase it even further, up to 2.5. I think that's probably more useful. As you also know, is that too much fluid is also not good because it can lead to hyponatremia.
Yes.
So you need to be monitoring mindful of that. So next slide. So malignancy here, you can see here there's different forms of malignancy. You can see urothelial, so there can be extrinsic causes, like you can have, it can be either urothelial causes, for example, in the ureter, that can cause blockage of a single kidney. You can have extrinsic causes, and one of them, for example, would be lymphoma.
Lymph nodes,
so lymphoma, it could be sometimes lymph nodes from bowel cancer, gynecological, pathology.
Could be anything.
That could be. So again, in this kind of setting, obviously you need to decompress them, and decompression preferably would be done, with a retrograde stent, but sometimes you can't do that, especially for pelvic malignancies. You might not be able to get a stent in place. If it is malignancy, the stents these days, there are different stents that we use. Some of the stents we can leave for 12 months, and hopefully that also reduces incrustation. So there are different stents. There can be, preferred stents still are the the standard sort of stents that we use, but they're a bit modified. So, for example, Rush stent is you can leave up to 12 months. I have used previously other like metal stents, like Memocath, which you can leave for longer, and it can drain the kidney. But what I find is that some of those stents can sometimes have incrustation, and even though you have a good lumen to start with, and it's a metal stent, but you can get incrustation. So you have to be careful and mindful, and be selective of cases that you use. I mean, if you have a malignancy where you're finding that the patient life expectancy is going to be less than 12 months, then surely, I mean, you can use the metal stent because you're not going to have any long-term issues. But if it's not, for benign disease, I'm a bit averse of metal stents. And the reason for that is because if you do get incrustation, and it's going to be very difficult for you to get those stents out.
Yeah. Do the stents cause a lot of renal colic? Do patients get a lot of discomfort from?
I mean, the ones that I'm saying, the metal stents, for example, you won't see that because they're a shorter stent, and they're not going into the bladder or the renal pelvis. It's only for the stricture, area of stricture. So that's why they're good, because it also gives patients quality of life.
Yes.
So they're not having constantly to pass urine. But the stents that obviously have double J stents, they will cause more issues in terms of frequency and urgency, and sometimes even hematuria. Yeah, and then possible infections sometimes. And so that's why you need to change the stents, because they get encrusted. You want to try and prevent infections, so you need to remove those.
Just in regards to referral management with these sorts of things, if you suspect somebody's got a malignancy that's causing obstruction, ureteric obstruction, what's the appropriate referral pathway for a GP? Because I can think of scenarios where you might do a CT scan, you can see PUJ obstruction, but you don't have a clear source of cause. What's the priorities of management?
Well, that's a good question, Maria.
And who takes responsibility for the on-referrals?
So the thing is, what you're saying is that I can see that there's a PUJ type obstruction, but there's no indication of any specific lesion that they can report. I mean, obviously in this kind of a setting, you need to do a referral. So the thing that I would do in this, like you mentioned, a CT scan. So you will do a CT IVP. So the CT IVP will give you the contrast study. You'll look at the lining of the urothelium, and the other thing that you would also want to do is urine cytology series, so 3 consecutive days. And I sometimes, even if they come in with cytology, I still repeat it, because sometimes, even as you know, in bowel things, you can you don't have to be initially positive, so it can be false negatives. So you would do that initially, and then if you're suspecting, when you check the patient, if you're suspecting that there is malignancy, you would then sort of go through the path of doing a piloscopy. So you will need to go into the kidney, identify if there's any hint of thickening, if there was a thickening of the urothelium. We need to visualize that and take samples and do selective cytology of the kidney, but also you might need to do a biopsy. If it is a pure PUJ, I mean, that's again, it's the one way that you would look at PUJ would do a DTPA scan. So you probably would have spoken about DTPA scans and MAG study previously with renal physicians, because they use them also looking at the function of the kidneys. So the way that we look at that is looking at the clearance of the kidney with a DTPA scan. It gives us a T-half clearance. If the T-half clearance is less than 10 minutes, then it's fine. And sometimes you can have pooling in the kidney, which is okay. But once clearance is happening, then you don't obviously need to do any intervention in that. If the area is grey, if the DTPA scan shows T-half clearance between 10 to 20, then it's a bit of a grey area. And if the patients have no symptoms, but it's incidental finding, you might want to observe it for a while. And you want to do another DTPA scan in 6 months' time. Okay? If, however, the DTPA scan shows a clearance of more than 20, then they need to have a repair. So you need to have a repair of PUJ obstruction. The way that I normally sort of do that is because in patients, one of the differential diagnosis is cancer, is malignancy. So I would go in, do a cystoscopy, do a retrograde pilogram, do a selective cytology on that side, put a stent in place, in view that I have already spoken to the patient that this will be our plan then to do a treatment for pyeloplasty in the future.
And so, if it's an extrinsic cause of malignancy, what do you?
Well, if it's extrinsic malignancy, then you just put a stent.
Right. And you recommend the GP sends them to who?
So for the malignancy, well, it depends on what malignancy is. I mean, if it's lymphoma, so they will need to be seen by a hematologist, and then we act basically in conjunction with them to say, look, we're going to leave a stent, unblock the kidney, they will have their chemo. If after the chemo things get improved, then that's good. But sometimes what you might find is that they can get retroperitoneal fibrosis.
Yes, I've had that in a patient. It's very difficult.
It's very difficult to treat.
No diagnosis.
And retroperitoneal fibrosis, which can also sometimes present with lymphoma.
Yes.
I mean, sometimes it can lymphoma can present like that.
Yes.
With POG obstruction and renal impairment.
Yeah.
And normally you'll find that you'll obviously need to do a biopsy to confirm that. Put the stents in place over a period of time. If there's improvement, then that's good. If you do have retroperitoneal fibrosis, they will need to have urethrolysis, which is a big procedure. Then you need to free up the ureters and then wrap them with omentum so that they don't get back into that same area. So it's a much bigger procedure.
Yeah.
So yeah.
Oh, we've already covered that, haven't we?
We've done.
We just talked about that. Shall I push to the next one?
We'll go to the next one. This is basically just a fancy slide just to show post-obstructive diuresis, pathophysiology, what happens. You get ischemia, you have lack of ability to concentrate the urine in the loop of Henle, and you get more loss of fluid done. And basically, that's the concept of the pathology. We'll go to the next one. We look at nephrocalcinosis. So if you look at nephrocalcinosis, again, these are the precursors of your renal stones, and usually happens in the
show just a picture of nephrocalcinosis.
This is the extreme of nephrocalcinosis. So sometimes what we do is we see on a CT scan. So this is obviously just a KUB. But we see on the CT scan, oh, there's a stone here. So you go in and you see, oh, wait a minute, there's no stone. So what happens is that these patients have got calcification in the papilla of the kidney, and you won't see that. Sometimes it's very difficult, but retrospectively, when you went in and had a look, there's no stone in there. When you look at them again, and you need to do, instead of just a pure CT KUB, what you want to do in that kind of a setting is either you want to do a retroepilogram, but which might not show it, but more importantly is to look at CT IVP. So the CT IVP will be able to show you where the calcification is after the contrast. So if you see the calcification is actually outside the collecting system and it's in the papilla, then obviously is nephrocalcinosis. And by and large, the nephrocalcinosis, you can see there, you basically need to do the blood tests. You need to do the 24-hour urine test. And again, this kind of workup really, we normally would pass on to the renal physician because they are much more clever than us plumbers.
It's complex. But these would be some baseline.
These are some of the baseline investigations. So you want to look at all of those tests and make sure that try and prevent it. So these are.
Sorry, just going back to that. So vitamin D can cause nephrocalcinosis.
Well, again, it's to do with calcium. So if your levels of calcium are fairly high, and it's not so much that it's directly causing it. It's more to do with auxiliary tests that you're looking at calcium levels. And deposition of calcium. And obviously the treatment, as we pretty much sort of have got taken into account all of this, depending on what you find, underlying condition. For example, if there's a parathyroid tumor, then you obviously need to do a parathyroidectomy. If it's renal tubular acidosis that the actual diagnosis, then potassium citrate is helpful.
Just remind me, what's renal tubular acidosis?
It is part of the nephrocalcinosis, causes of nephrocalcinosis. Renal tubular acidosis is the inability to retire acid in the renal tubules. So potassium citrate is to stabilize that. So again, fluid, we can never say enough. Lots of fluid, I think it's important. And is there any offending agent, any drugs that they're on, and that needs to be addressed? And if you look at the protein intake, I mean, there's a lot of stuff in protein. One thing that comes to mind is that you probably see this more in general practice, is that a lot of the younger people, for example, and sort of people that are becoming sort of middle-aged also, that are going to the gym.
Protein shakes.
Protein shakes, but creatine.
Yes.
And I recently just had a patient where he came in, I did a biopsy, he was okay. I booked him in for a radical prostatectomy. And luckily, I always try and do UECs again, just to make sure that there haven't been any changes. His EGFR halved.
Wow.
The EGFR was 35, so
wow.
I involved the renal physicians for that. I mean, we discussed it before the procedure. I put the patient in ICU, so I pre-hydrated him. So again, that one really links everything together.
Yeah.
So pre-hydration, so I pre-hydrated the patient the night before.
Yeah.
So I had plenty of fluids on board. I did him first in the morning.
Yeah.
On the list. We sent him to ICU afterwards. Again, hydration, maintaining good urine output after the procedure, and it corrected.
Yes.
But that was very scary to see.
Yeah, and that was because of protein, creatinine
he was
kinase.
He was on creatine. Yeah. So, and the exact mechanism was told by the renal physician that looked after him was, we don't exactly understand, but apparently he's on the proximal tubules.
Yes.
So somehow it clogs the proximal tubule. So it's something that always scratch under the surface and see what else is there that might be causing the problem.
Yeah, no, that's right. That's good. That's very good, Hodo. We've come towards the end. We've done very well for time. We've just done an hour now, which is fantastic. So I'm going to look to see if there are any questions. In the audience, you can see that I just put up our QR code for our evaluation. If you could please just scan that and provide us with your feedback. We're very happy to hear what you have to say about our presentation tonight. And I'm just going to have a little look to see what questions we've got here. So can you please describe about Bosniak kidney cyst staging? Oh yes, this is a good question. What to do with different Bosniak kidney cysts?
It's a good question. Bosniak cyst classification, best modality to use for that would be...
So this is kidney cysts, and this is on ultrasound? Yep. They're being classified.
You can see an ultrasound, but ultrasound is not the best to classify. So you would need to do a CT scan. Yeah. And even better than CT scan would be an MRI. Okay. So, but the sequence would be, you might find something on the ultrasound, you do a CT scan. So if you look at Bosniak 1 and 2 cysts, is benign pretty much. Yeah. Bosniak 2F cysts, then we start to worry. Yes. And you need to monitor it. Bosniak 3 is pretty much 50% cancer. Right. And there's a nodule there, enhancing nodule. Bosniak 4 is renal cyst, renal carcinoma, cystic renal carcinoma. Yes. So that's Bosniak 4. Yeah. So if you look at Bosniak 1 is your simple cyst. Yeah. So I say to patients, 50% of people above 40 years of age will have a cyst. Yeah. So that's normal. Yeah. Bosniak 2, there might be a proteinaceous cyst, or there could be a hemorrhagic cyst. So it looks a bit more dense. Yes. And sometimes CT scan might not be able to identify that. Yes. And that's where you go to the MRI. Yeah. So you want to basically assure the patient that this is not a tumor. Yes. Okay. And if it is a Bosniak 2 cyst, I normally say Bosniak 2 and 2F, monitor those with a GP with a simple ultrasound. How often? Once a year. Once a year. With a simple ultrasound. Indefinitely ongoing, or if it's stable? 5 years. Yeah. So I think that's 5 years with these ones. And if it is changing, obviously they need reevaluation. Yes. They need to have, it's increasing in size. Yes. They might need to have another MRI. Yes. Okay. So that would be pretty. And for Bosniak 3 and 4, they obviously need surgical intervention. Yeah. Okay. So the next question is very similar, which is about solitary cortical kidney cysts. What to do next? I think you've already answered that. So yeah. I mean, sometimes for very large cysts, kidney, if it's a simple cyst, what we do is de-roofing of the cyst. Right. So you do a laparoscopic de-roofing of the cyst. It's not something that we do very often. No. Why would we do that? Why? I mean, if patients, for example, have depending on where the cyst is. And sometimes what I've done is I've done a DTPA scan because they're saying, look, I've got pain. I've got pain and I've got obstruction of the rest of the collecting system. Then you might do that. But it's not very common. And sometimes the cyst can be 15 centimeters. Now, if it's a 15 centimeter cyst, I have done deroofing of the cyst. But it's not something that I encourage, and I often tell the patient, I could do your deroofing of the cyst, but your pain might not go away. Because it might not be related to that.
And is there, so sometimes on a report I might see it reported that there's an exophytic cyst. Is that more important than a cortical cyst, or is it just the same?
So they all can be exophytic.
So exophytic meaning it's sitting outside of the kidney.
Sitting, partially, they will be partially exophytic. So there could be an endophytic one, which means that it's buried into the tissue. Into tissue. And the rest of them can be 10% exophytic, 50% exophytic. And that will be also for renal tumours. So renal tumours can be endophytic and exophytic. So it's how much of it is protruding outside the cortical contour of the kidney.
And is there a clinical significance that's relevant or not really?
Not really. I mean, unless, for example, the cyst, as I said, is causing blockage of the collecting system. So if it's an endophytic cyst and it's causing blockage of the collecting system, then that's an issue. If it's a tumour of the kidney and it's purely endophytic, it can potentially have issues with terms of taking it out. Because if you can't see it,
you have to take the whole kidney.
You have to and sometimes what we do is intraoperative ultrasound. So you can sometimes see it, but it makes it more difficult. So it becomes higher risk that during surgery you would have positive margins because you can't see the outline.
Okay. Next question, also from an anonymous attendee. 3 millimetre non-obstructive calculus within the left inferior calyx. Does it need a urology referral? This is a good question because often we see these sort of incidental findings of a non-obstructive stone high up in the collecting system or up in the kidney. What do we do?
3 millimetres, just observe it.
Drink lots of water.
Drink lots of water. Keep well hydrated. Do the things and monitor it. The issue is that 3 millimetres, I would not go there and take it out. It's invasive. There are possible side effects and complications. If that stone decides to move, well, you know that more than 80% they're going to pass it. So we don't need to do anything. But if it becomes bigger, you need to be aware of it. You don't want for it to be forgotten. And then you're dealing with a 1.5 centimetre stone, 2 or 3 years or 4 years or whatever down the track.
And how often would you monitor that? I have to be honest, I don't think I've ever monitored one of those.
I would say, you can do ultrasound once a year.
Once a year.
I mean, and you might not see it on ultrasound. That's the issue. So this kind of. So if you do an ultrasound and you don't see anything, well, that's fine. You know that it's not small. It's a small one. So you're assured by the fact that it's small.
And the next question is a little bit similar. So bilateral non-obstructive renal calculi, a urologist referral was rejected. What monitoring do you do? So this is something that would happen here.
I don't know why they would have rejected it.
Well, I think the referral criteria now might be if it's not obstructive and it's, up high, they're not going to, it's as you said, they're not going to do anything.
Depending on the size, So these patients I would definitely refer to renal physicians.
Yes, would you?
Because as we discussed in the other slides there before, is we want to know what is making these stones. Can we stop progression of these stones? And new stones forming. So obviously if they have bilateral disease, this guy is a stone former or patient, male or female, it's a stone former. So they will definitely progress. And the idea there is that you want to try and be proactive. If they have, for example, you want to find out is it going to be reticulocytosis? Do they have nephrocalcinosis? So this potentially can also lead to kidney damage long term, and hence reducing your renal function.
Okay. So next question is from Robina. Is Reason, I've never heard of Reason, R-E-Z-U-M, Resume, available in the public system?
No,
sorry, you mentioned Resume.
No, it's not.
I've heard it today. Not available in the public system. Okay. So the next question, PET CT scan showed 22 millimetre left renal lesion, USG KUB partially exophytic hypoechoic lesion in the left kidney. What to do next?
Well, I mean, obviously, with an incidental finding of a renal tumour, that's what we're talking about here, is that especially if it's shown on a PET scan, so PET scans are fairly good at picking up also the renal tumours. What you want to do is the size of it looks like it's only
small,
22.
Well,
so
still,
it's a decent size, but I think what we do is there's been a shift in terms of what we're doing with these things, and depending also on the patient. So you need to look at patient factors. Okay. And you could do a biopsy, confirm yes, it is cancer. Now, if the patient has got a lot of other comorbidities, one thing that you will do is active monitoring. So you will monitor that. I would reassure the patient. I would say that any tumour that is less than 3 centimetres, a risk of any metastatic disease, because that's what they're worried about. Risk of any metastatic disease is less than 3%. So that's a good reassurance for them. And you will do scans every 6 months. Right? So you can alternate, sometimes do an ultrasound. Basically, what we're interested in here is looking at the change of size. So you want to do that. And then if it's a younger patient, however, you probably will benefit more from treatment. So doing a partial nephrectomy, depending on where the actual lesion is, doing a partial nephrectomy would be probably a better option because you don't want to subject these patients to scans every 6 months if they're 50 years of age. So whereas if the patient is with other comorbidities, you can even offer radiofrequency ablation. So radiofrequency ablation would be it's a focal therapy. So you put needles in, you do radioablation on that, and then you can monitor that. And sometimes, for example, if patients have got renal impairment for other causes, let's say that they're diabetic, if it's a small lesion, and they're elderly, radiofrequency ablation is a perfect treatment for them.
Okay, next one. Another one about the cysts. There's a lot of questions about cysts. Obviously, this was an important topic.
Well, you see this a lot.
4 by 3 centimetre loculated anechoic cyst in the lower third of the right kidney on ultrasound scan. CT scan showed a 30 millimetre cyst containing a solitary thin septum arising from the lower portion of the right kidney. So this is a Bosniak.
So this would be a Bosniak 2.
This
is a thin septum. If it's depending on the thickness of the septum. If there is mild enhancement of the septum, would be Bosniak 2F. Okay. So again, these ones you would monitor.
Monitor. Okay. The next one's a doozy of a question. When can I refer to the public urologist for BPH?
Well, I mean, I think
there are very strict
like we talked about. What we talked about in terms of management is you are the primary provider. So you would start them on medication. You would start them on different. I mean, I often talk to patients in terms of tamsulosin alone, combination duodart, and once you come if those medications are not working, then really surgical options need to be explained and discussed. And I think what we also need to discuss here is that we don't want to also leave the patients to have too much advanced symptoms, very high residuals. I mean, you can use the residuals as one of the criteria. So if you have a high residual difficulty, a lot of blood symptoms, high IPSS score, that means that they have a high IPSS score. So these are the criteria that we want to use.
And failure of other medical therapy. But if they've just got simply BPH without any of those, they're not really going to be accepted.
They're probably not going to be accepted. I mean, if you have mild to moderate BPH, should be amenable to medical therapy. So severe symptoms IPSS score.
Yeah.
I think which all of you will be doing in your private practice.
And, sometimes you see people who've got those sort of bladder trabeculations.
Yep.
That's just indication of
that's
lots
an indication
high
of that's an indication of long-standing bladder
pressure.
obstruction.
Yeah.
I like to show that when I do my cystoscopies. I like to show that to the patients.
Yeah.
But a lot of the cystoscopies that I do these days, I do them under local.
Yeah. Okay.
And
yeah.
I like to engage the patients, and this is what's happening.
Yeah. Yeah. Now, we haven't touched at all on hematuria, and it's probably a topic of its own. Do you have a pearl of wisdom about hematuria and what GPs should be doing in regards to particularly the investigation of that with view to referral into the public system or the private system?
Any hematuria is, as you know, it's serious.
Macroscopic,
Any microscopic hematuria, but even microscopic hematuria, we know that 20 times the high incidence of cancer. So if it's persistent, microscopic hematuria needs to be investigated, even though your scans are negative. Hematuria, urine cytology times 3, repeat it again, MSU, and you do a CT IVP. That's your primary investigation. And refer.
They need a cystoscopy.
They need to be
investigated.
I mean, often what I do is, if it's microscopic, what I do is, if I've seen the patient, I don't like to tell them, oh, I'm going to book you straight for a cystoscopy. What I do is I send a letter to the GP and say, we would recommend the flexible cystoscopy for the lower tract. And then after discussion with the GP, if you do want to go ahead with it, let us know, we can organise it for you. But I think that's the thing that, because sometimes patients say, well, I have no symptoms, I don't want anything done. You don't want to be also look like you are trying to do a procedure for these patients when they feel that they're not convinced that they need it.
No, because the risk is bladder cancer, isn't it? Because you're not going to pick that up. The
key thing that we worry is about
bladder cancer.
So sometimes you'll find that patients that have usually bladder symptoms like urgency, frequency that's starting, and they had it, it's a new symptom that they're complaining to. One of the things that we worry about is carcinoma in situ. So you might not see anything on the CT scan. You might not see anything on the ultrasound.
Cytology will be
cytology might or might not show anything. So you would expect with an aggressive form of CIS that cytology will come as abnormal, but you want to investigate that. So irritative voiding can be more so than the obstructive symptoms.
I'm going to take this as our last question here. We've got a last question asking about an approach to the overactive bladder disease investigation and management. I think this is a big topic all of its own, really.
Overactive bladder is a big topic. What we can say is that, if it's an overactive bladder and it's, like I said, new symptoms, for example, it can be also one of the issues that can be cancer. So you need to have a look at it. If you know if it's a new symptom, they need to have a cystoscopy for overactive bladder. Urgency, frequency, that needs to be investigated. So if, for example, now we are happy with the diagnosis of overactive bladder, then the management of that is bladder training. Physiotherapy, bladder training. What I have been doing for a number of years now, I've shied away from anticholinergics. And as you know, anticholinergics are implied on dementia. So what I do is I try and use Betmiga, Merovedron, 50 milligrams, and you can try 25 then to 50, depending on the effect.
It's not an anticholinergic?
No, it's a sympathomimetic. So it's got a different pathway. So it's less likely, and you can see that in a lot of geriatricians, for example, they like to use Betmiga. It's a good effective drug. Unfortunately, it's not on a PBS listing. But
I don't think the anticholinergics
I think most of them are not. So you will try that. So in conjunction, you can do physiotherapy alone, but it's not as effective. If you do conjunction with overactive bladder with a bit meager and physiotherapy, usually outcomes are better. Now, if you have to do a cystoscopy in these patients, you would also do a hydrodilatation.
Yes.
Try and stretch the bladder a bit to see that they don't have, and it can also be diagnostic.
Yes.
For example, in females, you can sometimes pick up patients that have got interstitial cystitis.
Yeah.
And that could be, you can see bleeding that can happen with that.
Yeah. Okay.
So that will be part of it. Now, if it is resistant to medical therapy and physiotherapy, these patients might also be candidates for Botox injection. So Botox injection is quite
effective. It can be effective?
Yeah, absolutely. Okay. It's very effective.
Good to know. Yeah. Excellent. All right, so I think that's our final question. So that brings us to the end. Thank you very much, Hodo. I think it was good. We were very interactive. Well done. Good evening, everybody. I hope you have enjoyed today's talk, and we'll see you next time.
Thanks,
Take care, everybody.
Thank you. Bye-bye.